Endoscopic tissue shielding to prevent bleeding after endoscopic submucosal dissection, a prospective multicenter randomized controlled trial. Introduction. Endoscopic submucosal dissection, ESD, for superficial gastric neoplasms has become established as the standard method of treatment in many countries. ESD was first developed in the 1990s as an advanced technique to overcome the limitations of conventional endoscopic mucosal resection, EMR. ESD has advantages over EMR in that resecting a tumor in an en bloc fashion is possible, regardless of tumor size, shape, or ulceration, contributing to accurate histological diagnosis of specimens and a decrease in local recurrence. However, ESD is technically difficult and involves a high risk of procedure-related adverse events such as post-ESD bleeding or perforation. Especially in gastric ESD, post-ESD bleeding is one of the most severe adverse events and may lead to serious hemorrhagic shock requiring blood transfusion or urgent surgery. Therefore, prevention of post-ESD bleeding is a clinically important issue that needs to be addressed. There are currently 2 established effective bleeding prevention methods: proton pump inhibitors, PPI, to promote healing of ulcers after gastric ESD, and coagulation of visible vessels in the post-ESD ulcers. However, even with these preventive methods, the rate of post-ESD bleeding is approximately 5%, signifying that post-ESD bleeding cannot be completely prevented with only these methods of standard care. Several reports have revealed that the use of antithrombotic agents and large resection size, greater than or equal to 40 millimeters, are significant risk factors for post-ESD bleeding. Considering the increasing population of patients taking antithrombotic agents and the expanded indications for ESD, including large intramucosal gastric cancer, the number of patients at high risk for post-ESD bleeding is expected to increase. Therefore, the development of another effective prevention method for post-ESD bleeding is desirable. Recent reports have described the shielding method using polyglycolic acid, PGA, sheets, and fibrin glue as a method of preventing ESD-related adverse events. PGA sheets are widely used in surgical fields as an absorbable material to reinforce suturing. In the field of endoscopic intervention, Takamoto et al. Originally reported the efficacy of shielding the ulcer after duodenal ESD using PGA sheets and fibrin glue to prevent delayed perforation. Tsuji et al. Performed a prospective pilot study to investigate the efficacy of this shielding method to prevent bleeding after gastric ESD in high-risk patients, those taking antithrombotic agents or those who were expected to undergo large resections, greater than or equal to 40 millimeters. The study indicated that PGA sheets and fibrin glue could decrease the rate of post-ESD bleeding. PGA group 6.7% versus control group 22.0%, p equals 0.04. Based on these reports, the authors hypothesized that PGA sheets and fibrin glue can decrease bleeding after gastric ESD in high-risk patients. In order to verify the additional effect of this method to prevent post-ESD bleeding compared with standard care, the polyglycolic acid and fibrin glue to eradicate bleeding ulcer in the stomach ESD for risked patient, Pager Buster, trial was designed. This study is the first randomized controlled trial, RCT, on the efficacy of the shielding method for the prevention of bleeding after gastric ESD. Background. Bleeding after endoscopic submucosal dissection, ESD, is a severe adverse event. Recent reports have described the efficacy of the endoscopic shielding method with polyglycolic acid, PGA, sheets, and fibrin glue for the prevention of adverse events after ESD. The aim of the present study was to investigate whether the PGA shielding method provides additional benefit in preventing post-ESD bleeding compared with standard care. Methods. This was a prospective, multicenter, randomized controlled trial. Patients at high risk of post-ESD bleeding were enrolled in the study. Before ESD, patients were randomized to either the PGA group or the control group. After completing ESD in the PGA group, PGA sheets were placed onto the ulcer floor and adhered with fibrin glue. The primary endpoint was the post-ESD bleeding rate. Results. 140 eligible patients were enrolled from September 2014 to September 2016, and 137 were included in the intention-to-treat analysis. 67 in the PGA group and 70 in the control group. Post-ESD bleeding occurred in 3 patients, 4.5% in the PGA group, and in 4 patients, 5.7% in the control group. There was no significant difference between the 2 groups, p greater than 0.99. Post-ESD bleeding tended to occur later in the control group than in the PGA group. Median 12.5 days, range 8 to 14, versus 2 days, range 0 to 7, respectively. Conclusion: the PGA shielding method did not demonstrate a significant effect on the prevention of post-ESD bleeding.